Okay, Georgianne, are you going to stay on or you're going to hop off? Or
I'm going to just stay on just for a quick minute. Hi, everyone. My name is Georgianne Moore. I'm the Senior Director of Education and Relations Fundraising here at Mount Sinai for the medical school. So I'm really proud to be here tonight and see all the students coming out to see Dr. Weiner, who is just an incredible alum who has an amazing story about how he came to and through medical school and really what he's done afterwards. So upon meeting him, I thought this was a story that needed to be shared with the students. So I hope you all get a lot out of tonight. We keep it pretty casual. Dr. Colvin will take the lead. I unfortunately have another meeting to get to. But again, thank you all for joining us. And Dr. Weiner, especially, thank you so, so much for taking the time to meet with the students.
thanks, Georgianne. So quickly, I just want to lay a few ground rules before we get started. So I want to try to keep it as informal as possible. I know pretty much everybody's off camera except for Thomas and Justin. Thank you. And Priya. If you want to come off camera, great. If not, that's fine too. But if you want to ask a question and you're in a place where you can come off camera, it would be great if you, raise your hand and then you can ask the question. Or if you're in the library or somewhere where you can't, just put it in the chat and then I'll read it to Dr. Weiner. So without further ado, I'm going to let Dr. Weiner introduce himself from wherever he wants to start, birth, or whatever age you want to start at. But he is a double alum of Mount Sinai, both from the medical school and from the residency. And Dr. Weiner, we're so honored to have you here. I'll let you kind of start your story from wherever you'd like to begin.
All right. Well, thank you guys for all joining, and it's exciting to be here and talk to my alma mater at Mount Sinai. Just a brief history of my journey. I grew up in the great state of Pennsylvania in a very blue-collar town, in a town near Wilkes-Barre, not even Wilkes-Barre. So people thought Wilkes-Barre was a city. So after that, I went to Boston University for a wrestling scholarship. And I started on a pre-med path by accident. I had no physicians in my family. It was all accidental. I then moved on and got into Mount Sinai Medical School. Very fortunate that was the case. And again, with no medical background, I didn't know what branch of medicine I would be interested in. But having wrestled in college and I played baseball in the summers, I started to migrate towards orthopedics. I then trained at Sinai, went to HSS, went back to Sinai as an attending, then was hired at Lenox Hill as the chief of trauma, and ultimately became the program director of orthopedics. So what I'd like to do is talk to you why I wound up picking orthopedics, but more than that, it's been an incredible journey and why orthopedics might be right for you. Because when I did this, I got very little guidance. And the truth is, the subspecialties, we had very little exposure. So you had to do it based on a very small experience and then sort of your own sort of marching orders. But for you, you shouldn't do it that way. You should make a really informed decision. So let me try to share my screen here. Okay, I got that. Where? Okay, good. So that was my little coach, my daughter's here, making sure I can do this. So, to me, orthopedics is an amazing career choice. And by the way, if any of you have questions, this is not a lecture. This is an interactive discussion. And what I want to do is just bring up discussion points so that will help us. So why is orthopedics an amazing career choice? So nobody really helped me with this. And, if I had a relative in medicine or a parent, maybe I would have been better off. My son's in medical school now. Maybe he's better off having me. I hope so, because I hope I can be not only a parent to him, but a mentor and an advisor. By the way, I didn't tell him to go into medicine. I didn't hope he went into medicine. He actually went to college and didn't start off in medicine, and he changed on his own. So just an important thing about me, I'm not that kind of person. I'm the bumper. I bump people to where I think they should go, my residents. And if they get off the line, then I throw some elbows. Sometimes I have to tackle them, but not too often. So when you choose a career in medicine, you have to decide whether, and it's okay if you don't have that in you, because interacting with patients and taking care of patients directly is really hard. And it's not hard when they're doing well. It's really hard when somebody's not doing well, when they're sick, they're complicated. And trying to help them takes everything you got. So if in fact direct patient care and direct interaction is not for you, then there's a lot of fields, a lot of great fields in medicine for you to choose. And even branches of orthopedics might suffice, but that's a personal decision. Then the other thing is you have to decide whether you want to be more of a primary care person or a specialized person. Coming out of Mount Sinai, a lot of us were really going to be specialized. It's an elite medical school. You see some of the best in the world. So, if anyone was going to go primary care, being from Bug Tussle, Pennsylvania, I might have gone back and done that. But once I got a taste of, the true expertise and how amazing some of these doctors were, it was like drinking from a fire hose. I wanted to see if I could be a person like that I could really up my game. And then for me, and I think for a lot of people, you want to make sure that there's growth in the field you pick. And it could be new treatments, it could be technologies, and it depends on what you like. Some people, I'm very mechanically oriented. Some people are very, chemically oriented and medically oriented. And, if you look at cancer treatment, it's incredible what's going on right now with the immunotherapies and the biologics. So, in fact, when I was training, general surgery went through a terrible lull where there was very little technological innovation, and they didn't get a lot of people that wanted to do it. And then, of course, the laparoscopic stuff and all the minimally invasive stuff came along. So that's important to me. You want to decide whether you want to be surgical or procedural. If you're not that interested in engaging with patients through their whole illness, you may want to be procedural and do interventional radiology, something like that. So, it's a style of medicine. It's not like you don't contribute. Some of the most important people in my life are the radiologists. And you can imagine that being true. And then, in the end, you want your career to be self-satisfying. And there's nothing better than making somebody well. Now, here's a cool thing about orthopedics. It's probably the only subspecialty or super specialty, whichever you want to call it, which is truly primary care. If somebody gets a swollen knee, if somebody hurts their back, if somebody gets some type of joint problem, gets injured, they don't call an internist. They find out through the grapevine, or they find out in their own way, what orthopedist should I go to? So you have to be a primary care specialist. So you look at this picture, this is a person with a swollen knee. And I'm not going to quiz you guys, but you got to go through the whole gamut of things that this can be inflammatory, it can be traumatic, it can be even oncologic. It can be a sympathetic infusion. It can be an infectious disease. It can be Lyme disease. And I can go on and on and on. And you have to figure that out. And I recently had a patient that came to me because she had broken her shoulder, and she kept telling me, "Doctor, I feel terrible. I just feel terrible. I can't, I mean, I'm tired, I'm weary, I'm this, I'm that." And finally, after she saw a number of internists, I did an arthritis screen, and she had inflammatory markers, but rheumatoid negative markers, and she had a rare form of seronegative rheumatoid arthritis. And the rheumatologist called me up and he goes, "She saw so many doctors. How did you do that? You're just an orthopedist." So I was very proud of that moment. And now that woman is getting well. Broken shoulder. And she came to me and I figured out what was wrong with her. So that's important. Now, what about this field? This field's incredible because it's all over the map. So if you just look at this list of things, if you're drawn to pediatrics and you want to be a surgeon, you can do pediatric orthopedics. If you like oncologic work and you really want to reconstruct things and do that kind of work, you can do orthopedic oncology. Spine, we'll go through a little of that. A lot of people love sports. I thought I would be a sports medicine doctor when I started, but I really was drawn to something else, so I changed. Geriatrics is very big right now. As people get older, part of our business is to really help diagnose and treat osteopenia and osteoporosis. Hand surgery is like a field unto itself. Between the hand surgery and the microsurgery, we'll talk about that. And foot and ankle is booming. So you may say, "Well, is that it?" No, that's not it. I just gave you a partial list. If you wanted to just do shoulder and elbow, there's a shoulder and elbow society. So you can get all over the body. I do trauma. So I operate on shoulders all the way down to wrists and hips all the way down to toes. So I get all over the body. The peds guys get all over the body. Clearly, the oncologists get all over the body. Some of the other persons in the subspecialty are more focused. So you can pick if you want to be more focused or all over the body. So this is a little bit about what I do. And if you look at the left slide, this is a crushed knee in a motor vehicle accident. And if you look at the center, this is us starting to this is in the operating room. I've now started to lift up all these fragments, align them, pin them. You see a dark spot in the middle of the screen, which I have the arrow. I hope you see the arrow. That's graft. And then if you look at the screen on the right, that's the fix. And then these are both cases from last week. This is a guy that went off a bike and completely, this is his collarbone. This is one side. This is the other side. This is fragments. And you can see we fixed his collarbone and got it all lined up. So I went from knee to collarbone. That's my kind of business. Now, trauma also, you do open fractures. I hope none of you are squeamish, but this is, a lady whose bone came right through the skin, and that's it. This is muscle, and we have to figure out a way to save this leg. And, there are guys now, I do tertiary trauma, but a lot of guys do primary trauma at trauma centers, and you catch this right off the highway. And you got to stabilize this, and you got to figure out a way to put the bone back together, not get an infection, get a microvascular surgeon, which might be your hand surgery team or your plastics team or both, to cover this so you save a person's leg. Now, what about robotics? That's a big thing. Well, orthopedics is deep into robotic surgery. It's a lot of the total joint people do it. I ran a course down in Philadelphia recently, and I hired a robotics team to show all the residents how to do robotic spine to put pedicle screws in. And it was incredible. The robot would go right over the spot and tell you when it's okay to drill. It's almost like cheating, but it's such a phenomenal tool to help us be more accurate. And the robotics are going to get bigger and bigger. They're not going to get smaller. You're going to throw in some AI and all this stuff, and surgery is going to be way different. So there are some surgeons that, you know, they don't need the robotics. They're very talented. They have great three-dimensional perception. They handle instruments well. There's a whole group of surgeons that they're very smart and they're good, but they're not quite as skilled, and the robotics make them better. So it's a great asset for us. What about microsurgery? Well, you know, now if you get into an accident and a bone cuts through a nerve, you can do nerve repairs. And now there's this has been around for a bit, neurotization, but you can actually piggyback a cut nerve into a live nerve, and that nerve will supply sort of that neurogenic impetus into a nerve that otherwise wouldn't function. So there's very exciting microsurgery if that suits you, if you don't like the big bony work. And of course, there's joint replacement. So joint replacement is the best operation in the whole wide world. You take a person that's suffering and disabled, and they wake up and they open their eyes and they go, wow, I'm better and I can suddenly walk again. And it's just like, I have 2 total hips myself, and it was just like that. I walked out of the hospital in a day. I got up and I went. And I, by the way, couldn't sleep at night. I couldn't sit in a chair. I was truly disabled. So phenomenal operation with incredible success rate. The slides you see on the right, this group right in here is a shoulder. And I'm just talking about this because I'm leading into something, into the technology portion of this. This was a guy in France that decided, because rotator cuffs can't always be fixed, so he decided to take the ball and socket of the shoulder and reverse them. And that's what it's called, a reverse shoulder replacement. Now, as a guy that's designed a lot of products, I looked at this when it first came out 10-ish years ago, and I said, there's no way the mechanics can hold up. This is one of the best operations that is growing by leaps and bounds for that sort of middle age entering elderly who want to be active and their rotator cuff is beat up. And I was completely wrong about this thing, which, you know, is you eat a little humble pie, but this turned out to be an incredibly durable and successful operation. So just exciting technology. This is, you know, what some of the spine surgeons do, and a lot of them are doing this with the robotics, with where they implant the anchors. Obviously, you don't want to engage the spinal cord. You don't want to clip the nerve roots. But this was a woman with a severe deformity, and this construct, you can see how straight it made her. So again, a very, very incredible technological advancing field. So I'm all about innovation, and I think that innovation is very important if you like it, in your endeavors. A lot of people say to me, you know, I had that idea a while back. And I say to them, well, you know, I kind of missed your patent. I missed your paper. Oh, no, I never did anything about it. Well, just a word to the wise. If you get an idea, pursue it. Because if you get an idea and you don't pursue it, you never had the idea. You can pretend like you had the idea, but you didn't, because you didn't do anything with it. So Stu Katchis and myself, I started a company called Nextremity Solutions in 2014. And we started cataloging and prototyping. It was started in Red Bank, New Jersey, near where I live. And we finally moved, and what you see is the giant plant we opened in Warsaw, Indiana. And the Innovation Center is there, and lots of doctors use this. Nextremity Solutions, by the way, is gone. I sold it in last year, and I sold it to a Swiss company called MedArtis. So it was incredible fun. It was incredibly beneficial to other doctors and patients, and was one way I contributed to the lore. So if you look, these are just a few of my ideas. So I used to design these things and I used to name them. So this is a modular wrist fixator on the left, and I named it Restore. Get it? Restore. This was a staple that basically had an arc so that the whole staple, in fact, the points didn't go in, the whole limb went in. So when you were compressing bone, you compress it. And then I had different radiuses so that those different radiuses had different amount of compression built in, so you could stack the force. And this one at the bottom is one of my favorite. It drives in like a wire, but it threads in like a screw, and it's reverse tapered, so you could over drill and use a nut to compress, and then you'd cut this in the back and it'd be customizable screw. So it wasn't a screw, it wasn't a wire, it was a squire, SCWIRE. And this one up in the corner, this one never came to fruition. It was, you know, I mean, an octopus has 8 legs, that thing has 6 legs. I wanted to call it a hexapus. The company that was looking at it refused to call it hexapus. They thought it was some kind of peculiar name, but that never made it to the market, but I did hold a patent on it. So, you know, you can't always be successful, but it's an exciting part of being a doctor and being in a technological field. So in summary, orthopedics is truly an amazing field. It gets you all over the body. It gets you from young to old. It gets you doing, you can do deformities, you can do arthritis, you can do any type of work that involves the musculoskeletal system. There's lots of surgical opportunities. There's incredible subspecialties and even super specialties. You know, you've heard I'm passionate about innovation, and it's an incredibly rewarding field. So that's my little talk on this. If you guys have questions, let's go.
That was great. Do you want to maybe take yourself off share screen and then we can see everyone?
Yeah. Oops. So how do I do that? There we go.
Perfect. All right, so I see some faces on the screen. If you want, feel free to take yourself off mute. And I can start if people are feeling shy. So obviously I agree with you because I'm an orthopedist as well. But how did you decide within orthopedics, your fellowship was in
pediatrics.
Okay, and then so how did you decide there and then go to trauma? And
yeah, so that's a really good question, and just so everyone hears, this is an important part of my story. So when I started, I did pediatrics at HSS, and back in the late 80s, there was a guy named Elizarov that came from Russia, from Kurgan, Russia, and gave his first talk in the United States of America. And he had designed specialized fixators, external devices, where you could drill pins and wires into legs or arms, and you could actually lengthen the legs, and bone would grow in between as you pulled it apart. But more than that, the arteries would regenerate, the nerves would regenerate, everything would stretch. And no one really knew why it was successful, except for the fact that as you put incremental tension on things, it was possible that certain things reverted into more of a stem cell type of module, and then they would regenerate themselves. So after I saw Elizarov's work, and I was going back to Sinai to man Elmhurst, so you guys can all appreciate that. And in those days, people were getting all these bad infections, plating, double plating, vulnerable fractures. And I developed an Elizarov type of treatment called hybrid fixation. I was the very first person to do that at Elmhurst Hospital. And I wrote up my first cases. I collaborated with a guy who's now chief at Boston University named Paul Tornetta. He was a intern when we wrote our first papers on P-Lon fractures and bicondylar tibial plateau fractures. So what happened right at that moment? In 1989, when I presented at the OTA in Toronto, I suddenly became a traumatologist. And I've been all over the world. I've been to Japan probably 15 times, presenting in the 90s. I've been to Australia. I've been to South Africa. I've been to Germany. I've been to England. I have presented that technique all over the world, and I just became known as a periarticular fracture traumatologist. And I spent years and years and years honing those skills, doing non-unions, doing, fractures that have been treated unsuccessfully. And it morphed my career. So my career, I still do pediatrics, but I do only pediatric trauma, deformity, growth arrests. I don't do club feet anymore. I don't do congenital deformities. I'm not going to open an infant's hip anymore. I'm out of that business. So that's how it happened.
Any questions so far? No. Akiro.
Hi, Dr. Weiner. Thanks so much for that awesome introduction to orthopedics. I was wondering if you could talk a little bit more about how you acquired your skills to become an innovator, and then also what you would recommend to medical students who are interested in incorporating innovation into their future careers.
All right. I mean, that's a great question, and it's a lecture unto itself. But let me I'll give you a little playbook on it. So first of all, everything you see in medicine, everything, I don't care what it is, was thought of, designed by, conceived of, however you want to put it, someone in medicine, right? Everything you see. So what you want to do is and most of what you're going to design or what you're going to innovate is going to be a change in the way people do things. And then you may modify a device to do what you think is the viable change. So the way I did it, my very first, after I did hybrid fixation, I worked as a consultant for a company that was called Ace Medical, because I used their contraption, not the Elizarov. I had my own contraption. And then that Ace Medical was bought by DePuy, and DePuy was bought by Johnson & Johnson. So I went for the ride. Now that was just pure luck. But after that, a lot of things that I designed, people would say, it would take a chance. So what I do, and what I did with my first independent invention, was restore. So I developed this modular fixator where you could either span the wrist or do direct fixation of fracture fragments. Then you could unlock the fixator, move the wrist. So I patented it on my own. First, you can get if you're not sure, you get a provisional patent, and that costs, a couple grand, $2,000-3,000 if you don't want to go all the way. So get some, that's the playbook, get some intellectual property. And then depending on what you want to do, once you have IP and you have drawings, you can then present it to companies. If you're not getting any traction and you really believe you got something, then you can get it prototyped. So the further you go down the line, the more value this is going to have, and the more legs it's going to have, and the more people can evaluate it. So, to me, it's IP, prototyping, and then the next phase would be to start to apply for FDA approval. So then you got to go testing. So you may want to partner up with an engineer or something like that. And for an individual, that's far enough. If it's going to make it, that's where you got to go. But certainly, if you get an idea, protect your idea, go for a provisional patent. The worst thing that can happen is you get 1.5 years to elevate that, and it gives you time to think. It also gives you time to present it to people. So I'm trying to develop a think tank now at Lenox Hill and Northwell, and we want to, as a department, if a guy gets an idea, we want as a department to create ownership. And I actually spoke to a couple of surgeons at Sinai to see if Sinai's program wants to get involved in that too. I just think the partnership of innovation and industry is an untapped resource and very exciting. And it ends up to be pretty lucrative too. But, it started off just as passion. And yeah, that's how I did it.
Pierce, did you have a question?
I did. My question is, with all the specialization and subspecialization, is there any future scenario where being a general orthopedist, whether that's in a global setting or a rural setting, is there a future for being a general orthopedist?
Yeah, so another really great question. And you guys, just before I answer that, I know you have questions, and they're going to be really good questions, because medicine is really complicated right now. So just so you know, even though I'm the program director at Lenox Hill, and even though I'm employed by Northwell for my directorship, my practice is private, and I'm a traumatologist in a little hospital, and I do all of their trauma work in a hospital in Red Bank, New Jersey called Riverview. There's a large group down there. They have specialties, but they function as generalists. And they try to refer the kinds of cases to the guy that's fellowship trained, but they still are generalists. They'll take call, they'll do all the fracture work. When it's a hard fracture, then they'll refer it to me. But I think there is still a lot of room for the general orthopedic surgeon. And even at Lenox Hill, we have guys that will do sports and fractures and cases that are related to injury, because a lot of, fracture work happens on the football field, on a bicycle, soccer, and such. So there's a lot of overlap. Now, would I venture in and do the spine? No. I think when you get to those kinds of subject matters, and I think sooner or later spine should be a separate residency. It should be combined with neurosurgery. I just think that it's so specialized that it's really not orthopedics per se. I really think it's its own self. So things like spine, you're not going to dabble in the spine. That wouldn't be fair to the patient. So, but I do think there's overlap. Foot and ankle surgeons do, let's say calcaneus fractures. I do tons of calcaneus fractures. So there's overlap. And I think there's a lot of room still for the generalist. Tends to be this: the further you go away from the metropolitan area, the more general the practices become. But if you're going to do total joints and you want to, have that as your really your pocket card, what I would say is you do your fellowship, and then you go into the community, you do general orthopedics, but you're the best total joint guy in the community. And that's what we have in Red Bank. We got a guy that does 900 total joints a year. I don't know how he does it, but he is a general orthopedist that he's so busy now he can't do the general stuff. But he's just a very good surgeon, and his fellowship now took, you know, he was total joint fellowship and it took him over. So that's kind of the landscape.
Julia sent a question in the chat. She said, what is the favorite and least favorite aspect of your job?
It's a really good question. You know, we are, as physicians, we're natural empaths, but we're not, and I talk to my residents about this, and I'm very careful how I express this, because as an empath, and a physician, I cannot feel sorry for a person. I cannot emotionally hijack myself. So you have to focus your empathic energy, we're natural empaths, on getting people well. And I do some of the hardest trauma work in the city, and I am so dedicated to getting them well that it's my proudest moment when I can discharge a patient who crushed their knee and their knee feels fine, and I say, hey, I'm glad I could help you. And therein lies my worst moment, my worst moment. And my worst moments are going to be people I can't help. And it's personally destructive to me. And I wish I was better at handling that. I'm just not. And that's why I say you got to be careful. You know, we're natural empaths, but we must try to be at least stoic enough to handle the bad times. And when you take care of patients, you're going to have bad times, and you have to endure that with the patient. And it's really, really hard. Really, it's the hardest thing in my life. I go to bed every night thinking about somebody. Every night. I'm doing this a long time. So that's a tough part of the business.
Renee, you had a question?
Thank you, Dr. Weiner. So my question is, how did you acquire the business skills to become like an innovator and company owner and a surgeon? Because I'm assuming that these skills aren't really taught in residency.
Yeah, great question. So I have no business skills, none, zero. I never took courses. I never got an MBA. I never did anything in that realm. So when I decided to build a company, and this is a lesson in life, what I did was I started to raise money, and I started with my best friends in the world who had a lot of money. And I told them what I was doing. I created a document for them to look over. I had already gotten a few patents on 3 products. And what I did was I created a board, and I learned business on the fly. It was all on the job training. And in fact, one of the big investors in my company it turned out to be a Wall Street billionaire. And I said to him, you know, when this is all done and we're about to sell the company, I said, maybe I should go to Wharton and take some courses and learn something about this. And he just said to me, he said, you sat for 5 years at a table with me, you could teach at Wharton, buddy. And it was the truth. I have learned, people call me up all the time now and ask me how to start their medical business. and I'm happy to help them. But I've learned an incredible amount, but it was all on the job. And, you know, I've had friends that were bankers and such, and they pulled us through that endeavor, which, by the way, we were bankrupt. We were about to turn the lights off 4 or 5 times. I had to reinvest. I mean, I almost went broke. I was so committed to this that I took all my savings, my family's money, and I put it at this company. Don't think that I just, you know, started and everything was hunky and dory. And the guy that really helped save me was this billionaire. He invested a lot of money, and then what he did was he dumped his stock and gave it to me and my partner for $1. So he made us. He's a very, very generous man who likes seeing his friends do well. So he made us, you know, money, a lot of money. So, but if you do want to do that, you get people around you. That's the take-home message. You get people around you. It's like anything else. If I'm doing an orthopedic surgery and there's a nerve that's injured, I'm going to get one of the nerve surgeons to work with me. I'm not going to try to fix the nerve. So it's all about sharing knowledge and collaboration. And when I interview residents, just so you know, if you come to Lenox Hill and do a sub-I, I'm going to tell you 2 things. One, you assimilate with the group, and 2, you collaborate. We don't want anyone to try to get ahead of the other person. We want everyone to be the cream, and we'll make you all really, really good. But I don't need someone to show me they're better than somebody else. I want you to assimilate, collaborate. The 2 most important things of any resident. No person starts to sink. You pick them up and help them, because that's our job. And that's kind of the way we ran the business. Everyone helped each other, and we made it.
So along those lines, as the program director, what other qualities have you seen that make residents successful versus ones that maybe are not as successful?
Yeah, so, you know, when you look at orthopedics, I mean, we don't get to use the steps anymore. And that's just recently, by the way. Last year, there still were a lot of step scores. But, and the only reason I bring that up is because I'm not worried about any residents being smart. We were taking people in the mid 250s, 255, 257. So we were getting people in the 90th percentile and from really good medical schools. So my biggest thing is that you have a work ethic and you're willing, as I said, to help the other person. You're willing to share knowledge. You're willing to do a little more to make sure the other guy isn't behind. You're willing to make sure that as a service, we are A+. And I trained at Sinai, and at Sinai, I don't know how it is now, but we were surgically heavy. We operated early on in our residency. That's not like some other programs, Columbia and some others. But at Lenox Hill, a person could be on my trauma rotation when they're a junior resident, and I just did a bicondylar fracture with a first-year resident. He did the whole case. Now I have my way of helping him, and you know, I'm a really hands-on instructor. I show residents everything: how to cut, how to put a screw in. You don't put a screw in right until I make sure you do it right. So everything to me is a learned skill. No one's born with this knowledge. So it's a marriage of exchange of information for patient care and training. And I think everyone at Lenox Hill buys into that. There's just a dedication that is through the roof with our residents. And we instill that right from the interview. You'll get that from the interview, from the sub-I. That's who we are. You're not invisible at our place. You are really visible. There's nowhere to hide.
Great. Any other students have questions? All right, great. Any last thoughts, Dr. Weiner? We covered a lot of topics there.
Yeah. So, I mean, just as a last thought, you know, if you do have questions or you're thinking about doing a sub-I with us, or any sub-I, you know, the whole thing about orthopedics is it's truly, it's almost like not a job for me. It's a life that I've lived in pure satisfaction, even though, like I said, there are some down moments, but it's something that you can find your way to real sensational medical career in this field. I am so lucky that I went down this path. Because like I said, my father was a dressmaker. He made dresses. So, by the way, I knew how to sew. He taught me that. And I'm a good seamstress. But having said that, other than that, he would say to me all the time, I wish I could help you, but I can't. And so I hope I've helped you guys. Because everyone could use it.
Do you mind if the students reach out to you?
Not at all. Not at all. They can email me. It's lweiner50@gmail is my personal email.
That's great. Thank you. I know we definitely have some fourth-year students applying to orthopedics on the call. So
Yeah.
we'll definitely be seeing you. They'll definitely be seeing you on the interview trail.
By the way, one little thing of advice, and again, I'm sure Sinai is similar. If you want to get into orthopedics, set your sight on a program that you think you can get into and do a sub-I and make sure they get to know you. Because these days, you know, grades are gone, steps are gone, honor societies are gone. Very, very hard for us to look at an application these days and make head or tail of it. So, you know, Michael Hausman, who, remember, I used to be in practice with, because I was at Sinai, wrote a letter about a resident last year, and it said this: if I could train one person in my life, this would be the resident. That guy's in Harvard. Now, I've never seen a recommendation like that, and I know Michael pretty well. And when he does something like that, he means it.
Mm-hmm.
Short of getting a recommendation like that, you want to get great recommendations now. And you really want to go to a program that you think you're going to be a good fit for them, and they're going to see that. If you're not, I don't want to categorize anyone, but let's just say if you're not Stanford material, don't go to Stanford and do a sub-I and write a paper and say, oh, it looks good on my application. I see that all the time. It doesn't look good enough to put you over the top. You know what would have looked good? You spent time with us and we got to know you and we really liked you. That's more important than spending a month at Stanford because it looks good. Because I know, you know, Serena Hu out at Stanford really, really well. And I could call her and say, do you know this person? And she may not even know you. So just be careful when you plan how you're going to, you know, tackle this orthopedic application process, that you don't do things that you think look good, or you don't do a sub-I at a program like NYU because they have 16 spots. I got a good chance. You go where you think you can make yourself important to that program. You should be important to that program. That you are going to honor that program someday by being a great doctor. And you should give the program a chance to train you, and you should give the program a chance to show them how great you're going to get. You don't have to try to, kick an 80-yard field goal. You should make it a chip shot if you can.
I've never heard of Michael Helsman saying that about anybody, so it must have been a pretty incredible student.
I read it and I had to reread it 80 times, and I interviewed the guy.
Yeah.
It was amazing. Michael is Michael.
That's definitely a once in a lifetime recommendation.
It absolutely was.
Thank you so much.
My
This is so
pleasure.
informational, and for offering your time and guidance even after this Zoom too.
It's my pleasure. Great
all right.
seeing all you guys, and good luck.
Have a great
Thank
evening.
you.
everyone.
Bye
Thank
now.
you.
For your time.